well, you've tried a closed reduction, unable to get a closed reduction, or say this is a younger patient, high energy mechanism, and you know beforehand that you may have to open reduce it, and maybe 3, 4 parts, or have subtrochanteric extension. Do you have any tips as far as open reducing and making sure that everything lines up? Any technical tips that you have
Sure.
that you've noted in your practice or through your years?
Yeah, one thing I think that is really valuable. So, in these fractures, we've almost certainly made up our mind we're going to put in cephalomedullary screws, which require a lateral incision, right? And then when you line up the guide and it's time to put the screws into the head, you have to make an incision for that. So, in most cases, if I'm having trouble with the reduction, I'll make that incision right off the bat. And to me, that's a free incision that I can use to insert devices to manipulate the fracture. So you see here inserting a K wire into the fracture to try and correct a little step off. A common thing I'll see is, you'll when you have the fracture lined up and you're going to ream it, it will gap the fracture open. I will use that incision to sometimes insert a bone hook and try and hook the inferior femoral neck to compress the fracture as we're reaming. You can put a hook around the femoral neck. You can apply a spiked pusher to the lateral cortex of the femoral shaft, again, to apply compression. So I try to take that incision and use it to my advantage. I found it's pretty hard to put a Weber clamp in through that incision just because the size of the person's thigh fights you a little bit. But you can insert all sorts of useful devices through that: collinear clamps, bone hooks, spike pushers. If you have it reduced, you can run K wires across the fracture to stabilize it provisionally before reaming. There's all sorts of stuff you can do.
And again, so you've noticed that typically when you're doing these, you try to put maybe one clamp on the inferior neck of the proximal fragment, and then another clamp, I guess, on the posterior shaft of the distal fragment. Is that typically the vector that you use that you're able to get a reduction?
Yeah, or even you're correct about on the inferior portion of the neck or the calcar, and then if you're trying a collinear clamp or a Weber clamp, putting the other tine on the lateral cortex of the femur, just something to compress that fracture together into a good position.
Okay. And have you ever used some of, because reading, I know there's multiple techniques you can use to help assist in your reductions. Do you ever use it when you put like a shank pin into the shaft to try to get your to try to assist with your reduction? Have you ever used that before?
Sure, I've found that useful in highly displaced subtroch fractures.
Okay.
That's where I think putting a shank pin in both fragments can be very useful. That way you have control over both of them. You can control varus and valgus. You can control rotation of the fracture. I find that to be very useful. Or sometimes just reaching in and grabbing both fragments with clamps and holding them aligned as the nailing goes on. I think you got to be willing to use all the tools available to you.
Right. And it's just, just some, fracture 101, like, if you see that you have a coronal fragment, that your clamps are maybe in the AP position versus, if it's a sagittal plane, it may be
Right.
going, laterally, pretty much whatever the fragment needs.
Yep.
And
Exactly.
are you, and do you, I've read a little bit about, the use of like a 4-hole semitubular plate to help get provisional fixation in difficult or highly comminuted or displaced fractures. In your experience, have you ever used that, or is that a technique that you've seen done before?
I think that's a really cool X-ray. I think that's a crazy technique.
Yeah,
I
man.
saw the paper about that. Some really smart people put that together. I think that more open approaches, things like this, are very useful if you're doing revision fracture fixation work where things are highly displaced and deformed and partially healed. But I think for primary fracture treatment, things like this are pretty uncommon nowadays.
Okay. And is there ever a case where you realize that you had to do like an anterior approach to the hip in order to get a reduction? Is that something that you've had to do for any type of intertrocks before?
I would say I haven't really had to open for extracapsular fractures like
Okay.
intertrocks. I've certainly opened for subtrocks, long spiral subtrocks, opened and clamped or cabled. I've opened for more proximal fractures like basocervical or femoral neck fractures for open reductions where you can't get an acceptable closed reduction.
Okay.
But I'm a big believer for these extra capsular fractures. You can generally get them well reduced, and get good fixation in them without massive open procedures for the most part.
Perfect. And I think we talked about it a little bit earlier when we were talking about the DHS screws or DHS plates that those allow weight bearing, but typically for most of your intertrocks afterwards, do you typically allow them to weight bear?
Yeah, exactly. You definitely do, because this is again, we're getting back to, these are mostly geriatric patients. Mobility is key for them. You got to have confidence in your fixation. You got to let these folks walk on them as much as possible. I'm almost 40, and I wonder if I could even get around with crutches or a walker if I had to.
Yeah.
Certainly, someone that's 70 or 80, they're not going to do so well trying to stay off of their legs. So you just got to let them go for it. So that's the idea behind stable, good reduction and stable fixation, is to let them bear weight on it.